I'd like to thank AFIP for being here today. I attended the course in 1985, and it was an excellent course. And so I hope I can contribute to an excellent course for all of you today. If we can start off by just looking at the handout that I provided, you'll find that ocular pathology is a very broad area, and it's hard to cover every aspect of it in 2 hours. At Michigan State, I have 16 carousels, so you can imagine condensing 16 down to 2, what it's like. So I'll just be very, very brief, and this will be hopefully a review then for all of you. I'll emphasize histologic and ocular alterations involving the intraocular structures especially. If we look at the handout, I gave you some general references. Also, I recommend that reviewing the veterinary pathology, especially in the past year. There's been very good articles on some ocular conditions reported especially by Wilcock and Pfeiffer. If you can't fix a globe correctly, or if you have problems with fixation and processing, then you'll never be able to evaluate those globes. So when I've given talks like this in the past, normally I start off by really emphasizing ocular histotechnology and fixation. But I end up talking for 45 minutes to an hour, and then I never get to a lot of the alterations. So instead, what I've done is in the handout, I've just mentioned some essential concepts in veterinary ocular histology, and I'll mention a couple in just a bit. Then the rest of the handout, I've mentioned ocular anatomy and histology. I'm not going to review the anatomy and the histology, but I have listed there some of the terms that you need to be familiar with. Then I mention embryology. In order to understand ocular alterations or anomalies, you need to understand embryology. And I'll touch upon a few of the ocular anomalies. But there I briefly mention embryology of the eye. Then I get into the alterations, and here I only list the terms. Really, ocular pathology pertains to really to all species, and you need to be familiar with the terms. The ophthalmologists are very familiar with these terms, and we also need to be familiar with the terms in order to describe the alterations accurately. So I'll begin with, as I mentioned, when you talk about the eye, you're really talking about a lot. Let's see, the pointer, let's see. Okay, you're really talking about a lot of structures. You're talking about the eyeball or the globe, the optic nerve, and these are all separate structures. The conjunctiva, eyelids, the orbital fascia, orbital muscles. And as you can see, this is a diagram from a dog, and they also have the zygomatic salivary gland within the orbit. And sometimes you'll see when there's exophthalmia or the globe is protruding, sometimes it's due to a neoplasm of the zygomatic salivary gland. So don't forget, especially in dogs, they have a zygomatic salivary gland in their orbit, and you can get carcinomas and adenomas of that gland. For the talk today, I'll orient both subgross photos and photomicrographs in the following way. The cornea will always be up and the optic nerve will always be down. So if I zero in on a particular lesion, you'll at least know the orientation. This is a canine globe. Just briefly, and I'll be real brief on some concepts on fixation. Booleans and Zinkers have been used in the past. If you're in a practice or in a position where you get a lot of formalin-fixed globes, I recommend injecting the globes, and I mentioned that in here. That also works if you're using glutaraldehyde, and I strongly recommend, if you haven't tried it, use Davidson's fixative. It's like a souped-up formalin. It's got glacial acetic acid in it, which is also the same ingredient that's in Booleans and Zinkers. With that, you don't have to worry about washing like you do with Booleans and Zinkers. So I mentioned that in the notes. You notice that the section is such that it's right next to the optic nerve. It's cut in a plane through the pupil. And then what you do, so this is the standard cut. Now, if you could look at the posterior aspect of the globe right here, you notice that there's two vessels that go in a horizontal plane around the globe, and you can see them in the sclera. And those are long posterior ciliary arteries, and that demarcates the horizontal plane. For all animals, you trim perpendicular to that plane, except for primates, where you need to trim parallel with that. The reason you trim perpendicular to it in most species, the reason you do is because you want to evaluate the tapetum as well as the non-tapetum. You also want to evaluate the tapetal retina as well as the non-tapetal retina, because, for example, in glaucoma, the tapetal retina, you'll see less alterations there than you see in the non-tapetal retina. So there are differences. There's also certain compounds that will affect the tapetal retina and not the non-tapetal retina. So that's why you need dissection like that. In primates, you want to trim perpendicular to that vessel so you can get the macula and evaluate that. One comment on rodent globes. You do not need to trim rodent globes. They're small enough, you can embed them, and then let the histotech just section the block, face the block until she gets into a plane that's just like this. You'll decrease retinal detachment and distortion within the rodent globes if you just go ahead and embed them. Okay, I'll begin by talking about alterations in the globe as a whole. And embryologically, remember that the globe originates as an evagination from the developing brain. And then this neural ectoderm interacts with the surface ectoderm. And you get invagination of the surface ectoderm to form the lens vesicle. Well, if you don't get that invagination of that lens vesicle, then you end up with a cystic globe. And this is a small globe. It's a microphthalmic globe. And you can see that it's just basically a cystic globe. And in many of these microphthalmic globes, and remember, there's two terms. There's anophthalmia and microphthalmia. Anophthalmia is extremely rare. You can see what the ophthalmologist may see clinically as anophthalmia, chances are is really a very severe microphthalmia. There is probably a very small globe in that orbit if you look. Anophthalmia is very rare. So we have a microphthalmic globe, but in many of these microphthalmic globes, you almost expect to find multiple anomalies in those. And one of the anomalies that's very common is to find cartilage within the sclera. So we have an example of cartilage within what would be sclera. At a higher magnification, you can see that this cystic globe is then lined by primitive neural ectodermal epithelium, and there's even a formation of a rosette here. Here we can see that the cartilage within the connective tissue that should have been sclera. Sometimes you may find cysts associated with this, and there's a nice picture of this in Saunders and Rubin's book. Again, this is from a horse. It's a very small globe. It's a microphthalmic globe, and notice the blue right here. That's cartilage. So again, we see that there's cartilage within this microphthalmic globe. Here we see another microphthalmic equine globe, and if we look at the globe, we can readily see the optic nerve here. If we go up to what should be cornea, we can see that there's thick tissue here, and if I showed it to you at a little bit higher magnification, there's hair follicles and all the features of skin. So you have a corneal dermoid. Well, the cornea, the surface ectoderm, or of the cornea, the surface epithelium is derived from that surface ectoderm. Then you get two waves of mesenchyme or mesectoderm moving in to form the stroma and the endothelium of the cornea. If you have a problem with those waves moving in, or there's faulty interaction once they do move in, then the cornea doesn't develop like cornea. It kind of develops like what's adjacent to it, which is skin. So it's not probably too surprising to realize that you can get skin developing within the cornea like that. We also see that there's really no lens present in this globe, and that what should be anterior chamber and these structures are there's just cysts, it's malformed, there's a lot of dysplasia present. And this is very common in these microphthalmic globes. Another common finding is intraocular glandular tissue. It resembles lacrimal glandular tissue. So if you see a small globe and you find that, don't be alarmed. It is actually a fairly common finding. Okay, so microphthalmia and anophthalmia is one alteration of the globe as a whole. Another one that you'll see is cyclopia and synophthalmia. Probably cyclopia only occurs really in Greek mythology. If you see these globes where you think you have a cyclopia, if you trim it, actually find that there's two globes there, and they're fused, and the degree of fusion is quite variable. So really, cyclopia, again, is extremely rare. I've never seen a case of it, or really a true report of it. So there probably is one out there someplace, but it is extremely rare. Really, the majority of these, and even in those articles where they talk about Veratrum californicum and that, if you look, they're really synophthalmia and not cyclopia. So the fusion of two globes here. Okay, in the developing globe, again, we have this, the optic stalk and this optic vesicle, and then the optic vesicle will invaginate to form the optic cup. Well, along the ventral aspect there, you have a fissure, a choroidal fissure or fetal fissure. And then that closes. And if you get failure of this closure, then you end up with a defect or a portion that is absent. When you have a portion that is absent, the term for that is coloboma. And this may occur, at least, and they talk about the ones which are in the area of the choroidal fissure as typical ones. When you see colobomas in other areas, they talk about atypical ones. Well, anyway, the cells that are right here are the developing cells for the sensory retina, and the cells along here, since this is all, we're just looking at the optic vesicle and optic cup here, will be the cells that develop into the retinal pigment epithelium. Now, if these cells proliferate at a greater rate than these cells do and don't do it in unison, then you can see how you might get a bulging down in here, and then that'll arrest or that'll prevent the closure of that fissure. So that's one theory behind why you get colobomas. Here we have retina. There's a bit of optic nerve right there, and many times these are in the area of the optic nerve in the adjacent retina. And there's choroid and there's sclera there. Well, we have a portion that's missing. Sometimes these are lined by this sensory epithelium here. It becomes very thin and actually disappears. So you see that many times these are lined by dysplastic, as we have here, dysplastic neural ectodermal epithelium, or it may actually be absent. Also notice that the choroid disappears. We don't have any choroid down here. So there's an absence of retina, there's an absence of choroid, and there's a dilatation or an expansion or this outpouching of the sclera, and they call that scleral ectasia. We'll also see the vitreous body here, which is kind of detached in that colobomatous space. Now, the hallmark colobomas are a hallmark of Collie eye anomaly. But really, the main lesion in Collie eye anomaly is choroidal hypoplasia. Here we have a globe from a collie, and notice that as we look at the posterior aspect of the globe, it should be pigmented. We should have a tapetum and a non-tapetal area, so there should be a blue or a green area and a black area. Notice that we're seeing the white sclera through a markedly thinned and actually absent choroid. So we have choroidal hypoplasia. And actually that is the only really consistent finding in Collie eye. There's a lot of other alterations, but this is the main consistent finding in Collie eye anomaly. We also have the coloboma within the region of the optic disc, and then the scleral ectasia. This is a microphthalmic globe from a raccoon. Just again to show another example of a coloboma. Here we see that actually there's detached retina, or maybe never attached retina, and it's present down in this colobomatous space, the scleral ectasia, absence of the choroid in that region. What I'm doing here is I'm actually projecting the tissue. This is tissue that I float on a 2x2 slide, and then I actually project that. So you can do that with some of the smaller tissue. You can do it for any tissue, lung, anything else, and it presents, and you can readily see the lesions. Also, this is a trichrome stain, which is also, as you can see, shows a lot of contrast. So you can see the various ocular structures. You can see the contrast between those very nicely. Okay, let's move on to the cornea and some of the alterations in the cornea. Here we have a cow with a ocular, kind of a serous, looks like, ocular discharge, maybe a mucoid nasal discharge. Notice that the cornea is blue, indicating corneal edema. This is a bilateral change, and it's the change that is characteristic for malignant catarrhal fever. Now there's three bovine diseases which have kind of ocular, three main ones that you might see on a fairly routine basis. There's IBR, which is mainly just a conjunctivitis only. There's Moraxella bovis, which I'll show you, or pink eye, in just a bit, and that's a central corneal ulcer. Then you have malignant catarrhal fever, and basically the change is corneal edema. Now a dog with infectious canine hepatitis may have a similar ocular change. What you're seeing is just corneal edema. Now, true as in infectious canine hepatitis, and also is true in malignant catarrhal fever, there's cells, these flatter cells with more vesicular type nuclei are the endothelial cells along Descemet's membrane. So the corneal epithelium would be up here, here's the stroma, Descemet's membrane, corneal endothelium, and anterior chamber. And we can see that there are cells that are infiltrating between corneal endothelium and Descemet's membrane. There's also cells migrating into the deep corneal stroma. Now, these happen to be lymphocytes in this particular case, which is malignant catarrhal fever. These endothelial cells are important. They're the main ones that keep the cornea clear. So if you see this diffuse corneal edema, you might suspect that there's something affecting those endothelial cells. You could have, whenever you have a severe uveitis, you get corneal edema. Again, there's an effect on these corneal endothelial cells. What's the histological change that you see when you see grossly corneal edema? Well, you get separation of the collagen fibers. The cornea is thicker because now you've got fluid in there, so it expands, so it's thicker. Also, there's separation of these collagen fibers. You don't see the discrete spaces, which is an artifact, especially with the Zinkner's fixation. Here you can see it's paler staining, and you can see the individualized collagen fibers. So you see that you know that there's corneal edema present. Some other changes of the cornea. Well, the cornea is supposed to be clear and non-vascular. So when you get invasion of vessels, such as here, you have neovascularization of the cornea. Oftentimes that's associated with or due to or part of inflammation, and inflammation of the cornea is a keratitis. And we have a hypercellular cornea here due to a keratitis. The ophthalmologist will stain the cornea and see if this is a fluorescein stain, and see if it's retained within the stroma. And when it is like this, that indicates that there is a corneal ulcer. You can see the stain here. I show that because I saw something similar like that when I took boards. So I kind of remembered that and thought I should pass that on. Okay, this is the eye from a cow. So what's the disease? We've got an area of central alteration here. This is pink eye, or due to Moraxella bovis. Now we've got kind of a healing ulcer, or this is scar tissue in there, and a term for that can be leukoma. Also notice that the cornea is blue. So we've got corneal edema. We also have neovascularization. Many times when you have deep ulcers, you may also have a uveitis that goes along with that corneal ulcer, and I suspect that there may be a uveitis going on in this particular case. That's why we have such diffuse edema, and we have that neovascularization present there. If corneal ulcers, and corneal ulcer now is one of the other alterations that I'm trying to emphasize, if that's very deep, it will go all the way down to Descemet's membrane. But Descemet's membrane is kind of tough and resilient, and may just, with the increased pressure here a little bit, will bulge forward, and then you form a desmetocele. This is a cat, and we can see there's corneal edema. It looks like there's some vessels in here and some white tissue, which is probably now some scarring of the cornea, and this bulging here is a desmetocele. This can rupture. These are very delicate in rupture, and then that's a problem. It may end up with an enucleation. Another change that we can see is edema of the conjunctiva, and that's chemosis. Okay, adherence of the iris to the cornea, like the corneal endothelium, is called an anterior synechia. If the iris is incorporated into the corneal stroma, it's called an anterior staphyloma. This is an example of an anterior staphyloma. Then kind of the next stage is where the iris is protruding through the cornea, and then that's an iris prolapse, which would look very similar to this, except it would be very black and actually seeing here it's shiny and it's still covered by some cornea. So we have an anterior staphyloma. There's a variety of causes of corneal ulcers. It can be due to a caustic agent. It can be due to a virus, especially like the feline herpes virus, and you can see intranuclear inclusion bodies present. Or it may be due to a fungus. This is superficial cornea. This is from a superficial keratectomy. There's no corneal epithelium present, so there is an ulcer. And I like the and this is from a horse. Now, just with a standard H&E stain, these black fungi were not, you couldn't see them very well. In fact, I overlooked them the first time I looked at it. But a stain that I like real well for the cornea is a GMS H&E stain. That way you know where you are in the tissue, and if there's a fungus there, you can see it. As you can see right here, is just numerous fungal hyphae present within the superficial cornea. There's also there's keratitis, and I think there's also some fibrosis. A ocular condition that is unique to cats, and which is seen especially in Persians, is the feline corneal sequestrum. And you'll see it grossly as a black area within the cornea. It's an area that is ulcerated. And also note that this cat now has brown tears. The white hair here is stained due to brown tears. Now, we've looked at this a bit and find out that the brown tears is not unique to this particular ocular condition, that cats with other ocular conditions can have brown tears. It turns out that since you have an ulcer, and on this particular slide, let's see, on this particular slide, you can see that now the ulcer is partially covered by epithelium here, but there's few nuclei present in here. It's kind of, so it's an actual area where there's been necrosis of the keratocytes in this area. There's loss of those, kind of a drying and a desiccation of this tissue, the superficial corneal stroma, and this pigment just from the tears just imbibes into the superficial corneal stroma. They do superficial keratectomies on these. Sometimes they reoccur, sometimes not. The pathogenesis of this is still being worked on. This is the eye from a dog, and this is cornea. Now we can see that the cornea is actually very opaque, and this is due to fibrosis, and it has kind of maybe a mottled effect with some red mottling due to vascularization of this area of corneal fibrosis. That is the appearance. Remember from vet school, they talked about pannus. Well, especially in German Shepherds, they call it degenerative pannus or a degenerative chronic superficial keratitis. It also is just kind of, you can see the same type of corneal reaction in any dog or any animal really, and it's really nothing that specific about it. In the German Shepherd, they feel like it may be an immune-mediated type of condition. But I show this just to emphasize how the cornea may react. You can, as I mentioned, you can get neovascularization, which we have. With that, you may get fibrosis. Here's the relatively normal cornea here. Notice that the collagen fibers are going in a lot of different directions. Up here, we have fibrosis. This is a very chronic change. Notice that these hypercellular areas are actually areas where there's a lot of lymphocytes and plasma cells. So they call that a chronic superficial keratitis. Also, another change that you may see, and which you see along with those changes, is migration of pigment and actually maybe migration of melanocytes. And they call this, when this is a predominant change, they call this a pigmentary keratitis. Here we see there is a central corneal defect, probably due to this lesion here in the lid. And now you see the pigment, the melanin pigment, that has migrated into the corneal stroma. Histologically, again, you can see melanocytes and pigment. Sometimes you'll see the pigment within the epithelium. So again, this is a chronic change. It's really not specific to the cornea, but it's just how the cornea responds. Another change, which is confined to the epithelium, and you can see in connection with this the stromal change, is what we term epidermalization of the corneal epithelium. You can see here the cornea, instead of being a uniform thickness, is now there's formation of reedy pegs, and you can actually get keratinization. So this is the term for this is epidermalization. Another change, again, which is kind of a non-specific change, but can occur quite frequently, especially in rodents, you see this, is one term for this. It's basically mineralization of the basement membrane of the corneal epithelium, but the term for this has been a band keratopathy. And we can see quite clearly here the mineralization of that. Now, when you have an exposure keratitis, that cornea is not bathed in fluid and it tends to dry out, this might be a change that you see. You can see this change in connection with some of the stromal changes, or you may just see it alone. And then some you can see it in older animals. But again, just remember that mineralization of this basement membrane may be a non-specific change. Also may be seen in conditions when there's hypercalcemia. Now, the term corneal dystrophy, there are certain special entities in human ophthalmology that are characterized as corneal dystrophies. In animals, it's a little bit different. In cats, sometimes you'll see edema, which has been termed a corneal dystrophy. There's lipid corneal dystrophies in dogs. And the term, the ophthalmologist used the term to mean a change that is primary, indicating that there's no inflammation or it's not secondary to something else, exposure or inflammation, that it is progressive, and that it is bilateral. And then they'll see these opacities within the cornea, and then they use that term in the corneal dystrophy when they've met those criteria. It's kind of, it's looser in the veterinary ophthalmology, but those are the criteria that they use for using the term corneal dystrophy. One, as I mentioned, that's been reported is a lipid corneal dystrophy. And I thought I'd show you what lipid looks like in the cornea. Again, this may also be a secondary change, but when you get it, you see that it's kind of yellow. In this particular case, we also have neovascularization of the cornea. But this arc right here is due to a lipid accumulation within the cornea. If you have a pretty tremendous inflammatory response, they call this a xanthomatous keratitis, and that's one of the features in those Cuban tree frogs that's been republished in veterinary pathology. Also, we can see, just to see other changes that happen to be in the slide, here's the margin of the iris, and we notice that there's an opacity of the lens posterior to that, so chances are there's cataract present too. Moving on to the lens then, remember the neural ectoderm of the optic cup then interacts with the surface ectoderm, and the surrounding tissue here is mesectoderm or mesenchyme. There's invagination of the surface ectoderm to form the lens vesicle. And notice, so this is anterior, this is posterior, and the lens, now this is a vesicle. Now the epithelium along the posterior aspect of this lens vesicle elongate and form the primary lens fibers in the lens. Then the epithelium that is anterior migrates to what is called the equator of the lens and starts to elongate and cover these primary lens fibers. And then this will start to form the cortex of the lens. Well, it's important to know that when looking at the lens. We can see, here's a diagram of the lens, and now we can understand why there's a capsule all the way around the lens. We can understand why the posterior capsule is very thin and the anterior capsule is thick is because you still have epithelial cells here producing basement membrane. So you're continually laying down basement membrane up here, so that's why it's thick. Now one thing that may happen when you trim globes is a lens may fall out. And I've had the histotechs or someone trim a globe and they've put the lens back in. And lo and behold, here's this thick anterior membrane right next to the retina. So they stuck the lens in backwards, and they're just trying to fool me. So, but I make the point that there is a difference here. These cells then migrate over here, elongate, and form the lens fibers. Now you can get alterations. So if you have epithelial cells migrating down here, that is an abnormality. And that's what we have here. This is some of the collagen fibers that's present within the vitreous body. Here's a very thin posterior lens capsule. Notice that there's lenticular epithelial cells along that capsule. So that's a lenticular alteration. And I'll mention some others in just a bit. Now, not all opacities of the lens can be considered a cataract. This is a calf that had diarrhea and was submitted. And notice that the lens is opaque. Well, this is a reversible change, and it's been referred to in the literature as a cold cataract. And it is kind of unique to calves, to bovine species. But the first time you may see this, you think, well, gee, BVD I think can produce cataracts in calves. Maybe and it had diarrhea. Maybe this calf had BVD. Well, this is a very, very common change, and it is a reversible change. So I just want to call your attention to that. It is not a true cataract. It is a reversible change. If you look at the lens, you cannot see any histological evidence of cataract. Okay, this is anterior lens. This is the epithelium of the lens. This is the anterior lens capsule. This is a pretty good fixation of the lens. And notice that you can see the lenticular fibers. They're pretty uniform in their appearance and in their distribution throughout the cortex of the lens. Now, some alterations. Well, that lens epithelium can undergo a proliferative change, and it can actually undergo a metaplastic change. Here is proliferation of lens epithelium, and now it's appearing like fibrous connective tissue. When you get breaks in the lens epithelium, this can extend out from the lens and actually be intermingled with the iris and the connective tissue of the iris. So proliferation of this lens epithelium. It is also one of the thoughts behind why you see a sarcoma developing in feline globes that have been traumatized. One theory is that the lens epithelium undergoes this metaplastic change and then undergoes a neoplastic change. There's some other theories on that, but this lens epithelium can undergo this metaplastic change. The lens fibers themselves can swell. When they swell, they're called bladder cells. And here's a nice example of bladder cells. The lens fibers can then fragment. They can round up, become hyalinized, and become eosinophilic spherules. And these are Morgagnian globules. I kind of like to get some wallpaper like this. Here we can see the swollen bladder cells. There's liquefaction, sometimes liquefaction of lenticular cortex. It has a granular appearance. Other time you see large vacuoles within the lens. All indications of liquefaction, all cataractic changes. Notice that the lens capsule here is wrinkled. When you see a wrinkled lens capsule, suspect that there's a cataract present because there's been liquefaction of the lenticular cortex, and in this particular case, there's been mineralization. So you can get mineralization of this necrotic tissue. Well, there's a wide variety of causes of cataracts, and that's several lectures in itself. Just thought I'd show you one example. This is the lens from a fish, and this is a metasaccarea within the lens of diplostoma. And this is actually a fairly common finding. Okay, well, the lens can do only about two things. It can liquefy or can undergo this cataractic change, and it can move. So if you looked at this and wanted to know two alterations that are present, one, it has a very wrinkled lens capsule. It's also not really kind of homogeneous in appearance, that you see darker areas and lighter areas and spaces in there. So you have pretty good evidence that there's a cataract present. Also, notice that it should be posterior to the iris and the pupil. It's in the anterior chamber. So you have an anterior lens luxation. Here's a subgross of a anterior lens luxation. Again, the iris should be in front of the lens, and also you should see a nice anterior chamber. Here we have the lens right in the anterior chamber. So there's anterior luxation of the lens. Now, the lens, when it develops embryologically, is covered by a vascular net, the tunica vasculosa lentis. And actually, if you look at a puppy, a newborn puppy, since their eyes are still developing after they're born for a couple of weeks, you can still find this tunica vasculosa lentis. And here are these vessels along the posterior aspect of the lens. I was just going to mention, as it gets time for there's a few minutes left, just stand up and I can adjust my talk so I know that I'm nearing the end of the time. I'll just keep going. When I see you stand up, I'll make my adjustments for the break. 15 minutes? Okay. Now, if we look at these diagrams, we can see that this tunica vasculosa lentis is in communication with the hyaloid vessels that come in through that choroidal fissure. And these hyaloid vessels and the accompanying tissue that surrounds them is basically been referred to as the primary vitreous. There's three types of vitreous. This is the primary vitreous. Secondary vitreous is what is present within the adult globe. And when you see that vitreous, that gel-like vitreous body, that's the secondary vitreous. And tertiary vitreous are the zonular fibers of the lens. So there's three types. And I'll talk about this right now. Now, those hyaloid vessels should regress. Those that look at rats know that these hyaloid vessels don't regress completely and may not regress completely, maybe even up to 6 months or so, and that they may bleed. So in rats, young rats, you may find, this is optic disc, retina, optic nerve. So you may find bleeding, just anterior to the optic disc. Well, so that's, and you can expect that. That can be a normal finding. Now, in cattle, there's incomplete regression of that hyaloid vessel, and you see this little remnant. Again, this is a pretty consistent finding. If you look at it, you can see a little white thing coming off the optic disc there, and it's called Bergmeister's papilla. So it's just a, incidental finding. Now, you can get persistence of that vitreous, so that all was pretty much normal, or you'd expect that. You may get persistence of that primary vitreous. Now we're looking at the posterior aspect of the lens here, and notice that there's a fibrovascular membrane, and actually now we have cartilage present in here. So if you get, and since that hyaloid vessel came up and communicated with the tunica vasculosa lentis, embryologically there are vessels here. Well, if they don't regress, you may just get a persistence of the primary vitreous. If it undergoes kind of a hyperplastic change, indicating that it's proliferating, and you get a fibrovascular membrane here, then it's persistent, it's hyperplastic primary vitreous. Persistent primary hyperplastic vitreous. And it's not, and you can see cartilage sometimes developing within that connective tissue. Now, the vitreous body can undergo some changes. It can liquefy, and actually this shrinkage of the, and it can undergo shrinkage and it can opacify. Well, you always wonder about the vitreous body as if this is an artifact or not, and actually it is quite a common artifact to have some shrinkage of this vitreous body. But if you find that there are a lot of inflammatory cells present within that vitreous body, then chances are some of that liquefaction or some of that shrinkage was a true change. Another alteration of that vitreous body, the secondary vitreous, is hyaloid asterosis. And this is commonly seen in canine globes that have ciliary adenomas. And if you look, you can find these basophilic spheres of variable sizes scattered throughout the vitreous. And there's really no inflammatory change. They're just kind of located within the vitreous body. And they contain lipid and they contain calcium. So asteroid hyalosis. Kind of an incidental finding. You may also have a vitriol abscess. And here we see a localized accumulation of neutrophils within the vitreous body. There's also a hemorrhagic retinal detachment present here. Now, in avian globes, it's probably, since avian globes contain scleral cartilage and bone, it's probably a good fixative is Boone's because it can partially or completely decalcify that bone and cartilage that's present in there. So Boone's is a good fixative for birds. The other thing to note that in birds, the globe is not a round shape. And I had histotechs that, not realizing this and know that I want to see round globes, or worked real hard and put it on the water bath for a long time and heated it up and just kind of ripped all of these structures apart, making a very circular globe. So if you're dealing with avian globes, especially tell the histotechs that they're supposed to be kind of a conical type shape. Also, some other differences in avian globes is that they have a pecten that overlies the optic disc. Reptiles have a conus papillaris, and fish have a falciform process, but birds have this pleated structure, very pigmented structure, which is called the pecten. And it's good to evaluate the pecten. In cases of, say, systemic aspergillosis in birds, you can get a very necrotizing pectinitis, as in this particular case here. So it's a vascular structure, probably provides nutrition to the retina. Since the avian retina is avascular, it probably does provide some nutrition. Anyway, it's a structure to evaluate if you're looking at avian globes. Moving on to the retina now. This is the iris and ciliary body from a rabbit. Rabbit have ciliary processes, and ciliary processes are a part of the ciliary body called the pars placata. The flat portion down here in the heads is called the pars plana. Anyway, I mentioned this. Notice that these ciliary processes are attaching to the posterior aspect of the iris. These are called irritable processes. This, it is normal for the rabbit, and possibly the chinchilla. Don't quote me on that one. I haven't seen that many chinchilla globes. But in the rabbit, for sure, it is a normal structure. If you find that in other species, it is a congenital abnormality. And in the development of the ciliary body and that, there is some attachment embryologically. It's just retained in the rabbit. Now, in the past year, it seems like there's been a lot of reports on the bone that is present in the ciliary body of old guinea pigs. And here we have ciliary body, and we can see well-formed bone within the ciliary body. This is a lesion that has been recognized for a long time, and just seems like recently there's been several articles on this. But it's a kind of an expected finding in old guinea pigs. Now, the uvea consists of the iris, the ciliary body, and the choroid. And as I mentioned, certain species have a tapetum, and it's important to evaluate the tapetum. Here we have retina is here, this is choroid, sclera would be down here, and here are the tapetal cells. And it tends to be relatively cellular in dog and cat, and kind of fibrous in horses and ruminants. And it is located in the superior aspect of the of the globe, of the choroid. It is a part of the choroid. Now, anomalies of the uvea. Notice here's iris. This is from a monkey, and we have a portion missing here. So it's a coloboma, of the iridoid coloboma. Some other changes. In dogs, you can find cysts. And this one you can see clearly is a cyst. Sometimes these are black, and some people want to confuse them with melanomas. We can also see that if we look through the pupil, here's the tapetum, here's the non-tapetum. Notice that we see a rim right here. There's also lens luxation or subluxation. So there's two changes present. These cysts sense as with the sensory retina and the retinal pigment epithelium, and you formed first that vesicle and then it invaginated, and then you've forming that cup. You've got a potential space between the two layers of epithelium. That's true for the iris, the ciliary body, and then the sensory retina and the retinal pigment epithelium. So it's only natural that you have a potential space there, and it's a space that sometimes can be dilated. And that is part of the reason why you might find these cysts in the anterior uvea. Here we see lens, iris, cornea here, and you see these membranous structures adhering to the cornea. So there's an anterior synechia adhering to the anterior cornea, originating here from the iris. Now you want to call these persistent pupillary membranes, and probably in the general sense, maybe that's okay. Actually, probably if they go up and attach the cornea, they're not. Probably this is retained mesenchymal tissue within the anterior chamber, and this is really more probably appropriately an anterior chamber dysgenesis. But whenever you see these membranes, especially in Basenji's, they refer to them as persistent pupillary membranes. And you can truly have those, but usually you see those extending from the iris and then may actually attach to the lens, causing a posterior synechia. An aging change that involves the basement membrane that is just beneath the retinal pigment epithelium, and is kind of a fusion of membranes there, Bruch's membrane. You see, especially in older humans, but you can also see in animals, these eosinophilic nodules located along Bruch's membrane, and these are called drusen. Now, a separation of the iris from the sclera in the ciliary body is called iridodialysis. A separation of the ciliary body, which we have here, from the sclera is a cyclodialysis. In this particular case, we see a lot of hemorrhage here. So we have a hemorrhagic cyclodialysis. This is usually, it's due to trauma. But just to introduce a couple of terms. Now, a condition that has been reported in veterinary pathology just recently, but it's been recognized again for some time, especially by Dr. Wilcock, is what's referred to as the pre-iridal fibrovascular membrane, or rubeosis iridis. We're looking at the anterior surface of the iris right here, and especially it's helpful in pigmented animals. And you see this, you can see it in horses, dogs, cats, cattle. I tend to get a lot of canine globes and feline globes, so I see it, quite frequently in those globes. Usually, unless they're an albino animal, the anterior border is pigmented, and this is the anterior border of the iris. Notice that there are vessels anterior to that. So this is clearly a true change. It's not just a way that we cut the tissue. And the other kind of differential here is many times you can find inflammatory cells accumulating on the surface of the iris. These are clearly vessels. They originate up near the pupillary portion of the iris, and then you see it extending down, and they can actually extend onto the corneal endothelium. Here we have a pretty severe case of the pre-iridal fibrovascular membrane, or rubeosis iridis. Now we can also see there's hemorrhage, there's migration of pigment-laden macrophages out into this, there's hemorrhage and a lot of fibrin in here, and then probably it's trying to be organized by this fibrovascular tissue. And you can see that this can be a cause of glaucoma because it completely occludes the filtration angle. So it's something that's been in the literature recently, and I thought I'd show you an example of it. If you look, you can actually find it. It's not rare by any means. In the ocular blood barrier in the eye consists of, in the iris, it's located at the point of the vessels. So when you get a breakdown of that ocular blood barrier, then inflammatory cells can move right out into the anterior chamber. In the ciliary body, it's located within the ciliary epithelium. So that's why a common change that you see in ciliary epithelium is edema. And it's because you can get the fluid moving out from the vessels, but it doesn't go past that barrier and just kind of accumulates there in the stroma. So ciliary edema actually is quite a common change. In the retina, it's located at the retinal pigment epithelium. And when you get breakdown of that barrier, the common, you would expect that you would get retinal detachment. And that's what's happened in this particular case. So this is a globe that's from a pig that had a Salmonella septicemia. We see that there's a hypercellularity, there's an iritis, there's fluid and probably cells within the anterior chamber. We also see there's retinal detachment. It looks like it's a serous retinal detachment because this just looks like granular proteinaceous fluid. And notice that the vitreous has a light pink staining. They call this plasmoid vitreous when it has this eosinophilic homogeneous appearance. Moving into talking briefly about iritis, or just uveitis in general. And to begin with, if you have inflammation of the iris, it's an iritis. If you have inflammation of the ciliary body, it's a cyclitis, choroiditis. And then you can have combinations of that. Iridocyclitis, cyclochoroiditis, you can have all those combinations. If all three are involved, it's a panuveitis. If the internal structures like the retina, the vitreous are involved, and the uvea is involved, you have, well, basically you have three tunics. The fibrous tunic is the cornea and the sclera, the vascular tunic, which is the uvea, and then the neural tunic, which is the retina. So if the neural tunic and the vascular tunic is involved, then you have an endophthalmitis. If you have all three tunics involved, you have a panophthalmitis. If the inflammation extends out past the globe, you have an orbital cellulitis. The optic nerve is separate. You can have an optic neuritis, you can have an optic meningitis. I'll show you some examples of that. So that's kind of quickly the terminology for uveitis. If you have a cataract, that's separate. You should indicate that separately. And maybe to be on the safe side, if you have corneal changes, you may want to list those separately. Okay, in this particular case, this is due again to that Salmonella septicemia. It's hypercellular. There's loss of detail. There's indication of necrosis. So we have an iritis here, necrotizing iritis, and there's fibrin and now cells out into the anterior chamber. An accumulation of cells. This is another case. Notice this. There's not many cells in the iris. They've all moved into the anterior chamber. They've gone through that blood ocular barrier, and now we've got an accumulation of neutrophils within the anterior chamber, and so we have hypopion. Also recently in veterinary pathology, there's mention in cats that a common cause of glaucoma is a lymphocytic, plasmacytic uveitis. Here we have an iris from a cat. Notice that all of these cells here are lymphocytes and plasma cells. We do have a lymphocytic, plasmacytic anterior uveitis. Anterior uveitis refers to iris and ciliary body. And it's occluding the filtration angle here, so we do have our glaucoma present. So this is an example of that. And apparently that's one of the leading causes. Now probably a common change is a lymphocytic anterior uveitis. That's pretty non-specific. You may see it in immune-mediated type of responses within the globe, maybe a response to lens protein or uveal pigments. It can be pretty non-specific. You don't know why you have a lymphocytic anterior uveitis. So that is a very common one, and it's really a non-specific change. Here we can see the ciliary body and the ciliary processes from a cow that has malignant catarrhal fever. And all of these inflammatory cells are lymphocytes and maybe some lymphoblasts that are in there. Just an example of a one disease that may cause a lymphocytic anterior uveitis. Now, cats with feline infectious peritonitis, it's common to find you may see a lymphocytic plasmacytic uveitis. You may find a granulomatous or pilogranulomatous lesions within the globe. This is a portion of the uvea. You can see that there's a lesion here, and they're often associated with vessels, pretty much what you see in the rest of the body. But if you check the globe, you can find lesions within the uvea and also within the sclera. A classic change that you see in horses that have had equine recurrent uveitis is that there's this hyalinized kind of membrane overlying the ciliary epithelium. Some have speculated that this is amyloid, maybe in part due to some basement membrane material. Some have speculated fibrin. Actually, I don't see globes from old horses now, but I do actually, just before I came, there was one that was submitted. So I'll have to go back and put some special stains on this to know exactly what this is. But anyway, this is seeing this hyalinized membrane like this. It's kind of unique to the horse that has had recurrent bouts of recurrent uveitis. Moving on to, another cause, as I mentioned, you may get a lymphocytic, plasmacytic type of anterior uveitis which is lens-induced. You get some leakage, slow leakage of some protein through the lens capsule. If you get rupture of that lens capsule, then you're really into a lens-induced uveitis. Here we have a this is necrotic lenticular material. Here, there's neutrophils. Notice there's macrophages here, all in response to the exposure of this lenticular material. Then peripheral to that, you'll see lymphocytes and plasma cells. Moving into granulomatous types of diseases within the globe, in recent article of Veterinary Pathology from Auburn, they reported on the VKH-like syndrome in the dog. And this is in a globe with lesions consistent with that. And you can see here's the iris, the ciliary body, and the choroid here. And notice that the inflammation is really mainly confined to the uvea, and it's the granulomatous type of response, also find plasma cells and lymphocytes. So it's a kind of, in a way, it's an example of a granulomatous panuveitis. In this particular case, it's much more extensive and probably even into a panophthalmitis. Different fungi may cause a ophthalmitis, if we use that as a general term, may cause a generalized ophthalmitis. Those organisms that tend to be intracytoplasmic, such as Histoplasma capsulatum, and also like protozoal organisms, such as maybe Leishmania, which are also intracytoplasmic organisms, what you see is diffuse thickening of the uvea, especially the choroid, but it can be the iris, ciliary body, and choroid. You may see retinal detachment, but this is just secondary. You can see it's a serous retinal detachment, and it's just secondary to inflammation of the choroid. So that's pretty non-specific. There's no cells with the organisms in here, but the organisms are found within the macrophages causing this hypercellularity of the uvea. Now, blastomycosis is one which you can also get diffuse uveitis, but you also get the movement of the cells and the organisms you find in the subretinal space. You can also find it within the vitreous. And so blastomyces or ocular blastomycosis is different than ocular histoplasmosis, and you can tell the two. The patterns are different. Here we see another canine globe. This is a example of ocular blastomycosis. We see inflammation of the vitreous body is called a hyalitis. So we have a granulomatous hyalitis present, and you can find the organisms there within the vitreous. Probably, if you just look at the reaction in general, reaction is very similar to that of ocular blastomycosis, is ocular protothecosis. And this is a globe from an animal that had, there's ocular protothecosis. And again, you can see a similar type response, this thickening of the uvea, and you can find the organisms out in the subretinal space and sometimes within the vitreous. Okay, the next one there. Okay, let's see. Oh, okay. Forward, reverse. Okay, another systemic fungi that may produce ocular lesions is coccidioidomycosis. This one, again, it's one in which you get kind of coalescing pyogranulomas within the uvea. And of the cases that I've seen, I found the anterior uvea involved. But people that are out in Arizona, the ophthalmologists tell me that the choroid is the initial site of ocular involvement, and the anterior uvea is affected later on. Regardless of that, you look for these areas of kind of coalescing pyogranulomas, and within the centers of these, you'll find the organisms. Another systemic fungal infection is cryptococcosis. And cryptococcosis is different from the others in that, one, there's minimal inflammatory response, usually. I've seen one exception to that rule, but usually it's very minimal inflammatory response. And you get a choroiditis, retinitis, and optic nerves not in the slide, but you get an optic meningitis. And it can be kind of localized like that. At a higher magnification, you can see there's minimal inflammatory cells. So it's very localized to the optic nerve, the optic meninges of the optic nerve, and the retina and the choroid. It's a complete discussion of fungal infections. This is an avian globe. Notice the pectin here, a lot of necrosis present, and this is systemic aspergillosis in a chicken. Quite destructive. Another type of granulomatous inflammation that can occur is with tuberculosis. This is a primate globe. You can see now there's necrosis here. There's all the basophilia is due to inflammation, especially granulomatous inflammation. So there's a granulomatous panophthalmitis. Probably there's a cataract. We can see the optic nerves involved. So we have a granulomatous optic neuritis and possibly a granulomatous optic meningitis. Okay, what are some of the sequelae to ocular inflammation? Well, one is the deposition of inflammatory cells on the corneal endothelium, and this is referred to as chorotic precipitates. You can get adherence of the iris to the cornea, which is an anterior synechia. You can get adherence of the iris to the lens, which is a posterior synechia. And when you get a posterior synechia, which completely occludes the outflow of aqueous here, then you get buildup of aqueous. It kind of pushes the lens forward. You get a peripheral anterior synechia, and you formed an iris bombé. Other changes, if the pupillary margin of the iris is bent inward, it's called an entropion UV. If the pupillary margins of the iris is bent outward, it is called an extropion UVA. If you get a fibrovascular membrane extending along the anterior surface of the lens from the iris, it's called an iridoid membrane or iris membrane. And this is the lens. If you get a fibrovascular membrane extending from ciliary body to ciliary body along the posterior aspect of the lens, it's a cyclitic membrane. The globe may shrink, and what the ophthalmologists refer to as become a tesical globe. This is ptesis bulbi, where you have a very atrophied, shrunken globe. Another term is atrophic bulbi, but and there's differences between the two, subtle differences between the two, but basically when you see a small distorted globe like that, it's called ptesis bulbi. Whenever you have inflammatory cells within the iris, you may get distortion of the pupil, especially the pupillary margin. This is a globe from a chicken. You notice that it has a very irregular pupil. In this particular case, the cellular infiltrate is a feature that is characteristic of ocular Merrick's disease. So ocular Merrick's. Moving on to neoplasms. The most common primary neoplasm of the globe is the melanoma. This is a human globe, And notice, and this is a melanoma within a human globe. And human ocular melanomas tend to be choroidal. And there is the calendar classification for grading these neoplasms. That was used initially to grade canine melanomas, and quickly found out that it is of no use. The human melanomas are different than the canine melanomas. The canine melanomas are different from the feline melanomas, and it's probably those are different than the equine melanomas. So each species, the melanomas have their own biological behavior. And so you can't use a criteria for one species in looking at another species. There's basically three types of canine melanomas. The first type is the anterior uveal melanoma, which we see right here. Histologically, you can see that it's pretty much confined to the iris ciliary body and may extend into the choroid. Sclera is uninvolved here, and it's just localized right there. The majority of these are composed of discrete polyhedral cells that vary in size, containing their cytoplasm is heavily laden with melanin. That is the most common type of ocular melanoma in the dog. Some may be composed of fusiform cells. The main criteria that you can use for distinguishing a malignant from a benign melanoma is the mitotic index in the dog. It should be less than 2 per high-powered field in the dog, and usually those that I just showed you, you can hardly find a mitotic figure. If you're starting to really recognize mitotic figures, then you might be thinking that this could be a malignant neoplasm. The malignant canine anterior uveal melanomas that are malignant are far less common than those that are benign. And those that I've seen that are malignant, you can see invasiveness, you can see a lot of anaplasia, so you really have no problems in saying that this is malignant neoplasm. Both the benign and the malignant forms can continue to expand within the globe. Even the benign forms may become quite large and end up in enucleation. They result in glaucoma, and then the globe is enucleated. Another type of canine melanoma is the choroidal melanoma, and usually this is adjacent to the optic nerve, and again, the morphology is very similar to the benign anterior uveal melanoma. The other type is what's referred to as the limbal melanoma. The junction of the junction of the cornea and the sclera is the limbus, and these occur at the limbus. Again, these are benign, and the problem with these is that they may extend inward, and they may actually extend within the globe, and then the end result is enucleation. But the biological behavior is benign, and they are very similar in morphology to the choroidal and the anterior uveal types. Now in the cat, it's a different story. Cats, if we look at the iris, you can start to see that there's a diffuse pigmentation, increased pigmentation of the iris. And ophthalmologists, when they see that it is confined to the iris, there's no other ocular problems, there's no glaucoma, they just tend to watch these and let these go. And probably at that point, where they're only confined to the iris, they are benign. And here you can see an accumulation of melanocytes present within the anterior iris of a cat. You can also tell the difference between a cat globe and a dog globe if you look at it, because the melanin pigment in the cat is much lighter staining than in the dog, which is quite black. So you could recognize that as a feline globe. Just as well here, see how it's a brown instead of a black, so you know that this is a feline globe. Note at this point, when it gets to this point, now in the dog, this would still be probably a benign anterior uveal melanoma. In the cat, this is most likely malignant. I would say in general, they are probably malignant if they have extended past the iris and involved the ciliary body. And that's probably your main criteria in the studies that they've done where they've tried to find what criteria you can use to evaluate these. In the cat, they can be quite pleomorphic, more so than what you see in the dog. And some forms can be quite amelanotic. Here you see that it's almost composed of cells that have more of a histiocytic type of appearance. You might find it hard even to find, you can see some melanin granules there, and these are probably just melanocytes that are entrapped in the neoplasm. But if you look, you can find some granules within the cytoplasm, but they have more of a histiocytic type of appearance. Notice there's quite a few mitotic figures present in that field even. Well, these will tend to metastasize. And here you see the lung, and you see a feline melanoma, anterior uveal melanoma that has metastasized to the lung. So in general, in the cat, I usually think of it as a guarded prognosis with a chance of metastasis, and the metastasis may be late. You may not even recognize it for years afterwards. So melanomas is the main intraocular neoplasm, the main primary one. Other primary intraocular neoplasms are the ciliary adenoma. Here we see a ciliary adenoma in the canine globe. Notice it is just confined to the iris ciliary body, no involvement of the cornea or the sclera. And they're well-differentiated cells, few, if any, mitotic figures. It looks just like ciliary epithelium. So they're benign, and you can see those from time to time. Here's another, from another portion of it, wanting to also mention that anytime you have uveal alterations, inflammation or neoplasia, you can find that there are melanocytes that take up, not melanocytes, macrophages take up the pigment, and you can find these scattered around. You can also see this type of change in globes from old animals if you look, and it just means that there was probably frequent bouts of uveitis and it cleared up early on in the animal's life. You also may find nests of very clear cells within these ciliary adenomas, and they are benign. In comparison to the adenomas, the ciliary carcinomas do infiltrate into the wall, and that's probably a good criteria to indicate that it is a carcinoma. Also, they tend to be not as well differentiated, and here you can see it extending into the sclera and possibly into vessels within the sclera. So even these have a low potential of metastasizing. Kind of in general, except for the cat, in the dog, even when you have a neoplasm within the globe, they tend to be benign and just stay confined to the globes. Although, you may, sometimes when you're dealing with carcinomas, you may find occasional metastasis. Those are neoplasms arising in well-differentiated or fairly well-differentiated ciliary epithelium. If you have neoplasms that are arising from neuroectodermal epithelium that is less, it's not as well differentiated as the ciliary epithelium, such as this, you're dealing with a medulloepithelioma. And many times they are located in the same area. They would have a similar type gross appearance. And this one, since it's very confined right here, would probably have benign biological behavior. You can see that these cells are kind of poorly composed. The neoplasm is composed of poorly differentiated cells, and you may even find areas in there which you find tissue that looks like skeletal muscle or bone, or sometimes bone, but especially neural tissue. When you see that, they're called teratoid medulloepitheliomas. Again, there are some that are malignant. Again, I think the majority of them are probably benign. So another primary ocular neoplasm is the trauma-induced feline ocular sarcoma. Here we see optic nerve, what's left of the globe, which has been almost totally effaced by an ocular sarcoma. When you see these ocular sarcomas in feline globes, try to get the history and see if there's been some trauma to that globe. And then this has been as documented in the literature recently by Dick DeBelzig, who's been studying this. You may find there are typical sarcomas. Sometimes you can find multinucleated giant cells within these. Sometimes they appear to differentiate into osteosarcomas. But as I mentioned before, it's probably, or one theory is that it's arising from altered lens epithelium. And usually in these histories that he's looked at, there has been trauma actually penetrating wound and involved the lens. The most common secondary intraocular neoplasm is lymphosarcoma. This is a globe from a cat with lymphosarcoma. We're looking through the cornea and seeing a white mass that is extending from the iris. These can be kind of just localized to the iris in ciliary body. It's a diffuse sheet of neoplastic lymphocytes, or they can totally efface the globe, as in this particular case. Again, this is the most common secondary or metastatic intraocular neoplasm. Now, you'll see in the literature from time to time reports of various neoplasms that have metastasized to the globe. And really, I tell the students that if you open up an animal and you find that there is kind of widespread metastasis, chances are it probably has gone to the globe. And probably there's actually maybe not that many reports, because maybe for a long time people never looked. And nowadays people are tending to look. So it's kind of like no looky, no findy. So when you see these reports, don't be alarmed and say, gee, that's another one that's gone there. I really don't find it that alarming. If it's something that is widespread, then chances are you probably will find it in the globe. Sometimes they're small. Here we see a little carcinoma that's metastasized to the ciliary body. And they can either involve the ciliary body or the choroid, and I haven't found a way of really differentiating the two. Some people speculate on that, but I see it metastasized to both sites, both up in the ciliary body and in the choroid. Here's a metastatic osteosarcoma to the globe, primarily involving the choroid. Here we see this is the retinal pigment epithelium. This is the tapetum. This is, I think, for my cat. We have the choroid here, the remainder of the choroid. And notice the vessels in the choroid now are just lined by a metastatic squamous cell carcinoma and actually starting to produce some keratin. Notice that there is retinal detachment. We know that's a true retinal detachment because you see the hypertrophy of these retinal pigment epithelial cells. Also notice that the retinal pigment epithelial cells are not pigmented when they're overlying the tapetum. Okay, moving and talking about glaucoma and the filtration angle. Basically, the filtration angle, and there are several definitions, but a good working definition is really that angle that is formed by the iris, and then up here is the cornea. And you get pectinate ligaments that extend from the root of the iris that go up and insert on the end of Descemet's membrane. So if you're wondering where that angle is, find the end of Descemet's membrane, the root of the iris, and now you've got your angle. This area down in here is called the ciliary clef. And you can generally refer this as filtration meshwork in this region. And these are the scleral venous plexus. So aqueous drains through here and then out into the scleral venous plexus. So this is your angle, and this is filtration meshwork within the ciliary clef. This is the angle from a basset, a young basset. And this is an example of what they refer to as goniodysgenesis or dysgenesis of this within this region here. And gonio because they're gonioscopically this is malformed here. You can see here's the end of Descemet's membrane is about here, and now there's been some kind of extension on here. It's kind of difficult. Many times they're very fragmented. Descemet's membrane ends up and it's very fragmented. But we've got the formation of a false angle. Really, this iris should be back here, and you should have a pectinate ligament coming out here. So actually, the iris is collapsed down, and we formed a false angle right here. The filtration meshwork here is never developed. Okay, the end result when you occlude that filtration angle is glaucoma. Some of the lesions of glaucoma include buphthalmia, or in a large globe, corneal edema. In some species, you can get separation or breaks in Descemet's membrane and resulting in corneal edema. We look at a section of the globe in which there is glaucoma. There's atrophy. Notice you don't see only ciliary processes. There's, well, first off, there's kind of thinning of all tunics, the sclera, the uvea, and the retina. There's thinning of the tunics. Atrophy, uveal atrophy. Notice you don't see the ciliary body. You may have some corneal edema. When you get that much atrophy, it's almost you'd expect the lens to, because zonular fibers are no longer, can't hold the lens in place, that you'll get displacement displacement of the lens. We'll talk about the retinal changes just a bit, and you can see cupping of the disc. These are all features of glaucoma. Now, it's nice when, for a pathologist when they remove the globe and you get to see all these effects of glaucoma. But the ophthalmologists tend to want to preserve that globe. So what they'll do nowadays is do an evisceration, which is that they basically suck out everything. They suck out the internal contents of the globe, leaving the cornea and the sclera. And then you end up with something that looks like this. Then they submit it to the pathologist and want this evaluated. And like all pathologists, we want to see nice tissue that's well oriented and really just say yuck when we see this stuff. What I advise is to make multiple sections in this so you look at as much of this tissue as possible, and basically what you're looking for is the presence of neoplasia or not. And don't really worry about the organization of that tissue so much, because if there's an intraocular neoplasm in there, even if it's benign, it's still, if there's some left, it still may enlarge and you end up doing a nucleation anyway. So that's really what the ophthalmologist wants to know. What they do is after they do that, they put in an intraocular prosthesis, which really looks like a super ball. And here we have a dog that has an intraocular prosthesis. And all the black is like this little super ball that's now in its globe. And because dogs and cats, they have a large cornea, and we normally see a lot of their iris or a lot of a pupil, we don't even notice that there's intraocular prosthesis in there. So that's why the ophthalmologists like to do that. Okay, talked about the embryology. I want to emphasize the fact that as you form this cup, you get an infolding then of this neural ectodermal tissue. This will develop into sensory retina. This is retinal pigment epithelium. There's a potential space between it. Up here, this will be the epithelium of the iris in the ciliary body. And notice that up there, the cells are apex to apex because of this folding. So again, there's potential space up here. So that's why you might see separation from time to time. How do you know when there's true retinal detachment? Well, if there's an exudate within the subretinal space like this, which is from a globe from a cat, and there's a serous retinal detachment here, you know that that's a true retinal detachment. The hallmark is this hypertrophy of the retinal pigment epithelium. And this is a pretty good example of hypertrophy of retinal pigment epithelium. This is an example of retinal dysplasia. I'm moving into talking about retina now. And the hallmark of retinal dysplasia is the formation of retinal rosettes. Also, many times you see folds, and sometimes they're continuous, but the rosettes, seeing that, and actually folds, many times you'll find folds with them. Okay, some retinal changes then. An aging change that you can see quite commonly is at the periphery of the retina. And here we have the ciliary body. The junction between the ciliary body and the pars plana here and the retina is the ora ciliaris retina. And right at that portion, you have peripheral retina here, and this is peripheral retinal cystoid degeneration. You probably start to see it maybe around 8 years of old when dogs are about 8 or so, but especially if you see globes from older animals, you'll see this change. It's a normal aging change. Another retina may be involved in diabetes, and when you do a trypsin digest and digest all of the tissue away except for the vessels, you can find the aneurysms and probably hyperplasia of endothelial cells, characteristic of diabetes. Now, the retina is basically composed of 3 cells. I'm going to really simplify this. People that are interested in the retina will probably be upset, but just for interest of time, I'm going to simplify this for us. You have starting down here, the retinal pigment epithelium, and then there's that potential space, remember, between that and this, which is the sensory retina. You have photoreceptor cells here, both outer segments, inner segments, and there are nuclei which are located in this outer nuclear layer. Then they synapse with bipolar cells and cells that are located, that have their nuclei in the inner nuclear layer. And the synaptic zone is the outer plexiform layer. And the synaptic zone between ganglion cells and these bipolar cells is the inner plexiform layer. Then you have the ganglion cells located here, which send their axons to the optic nerve, form the optic nerve. So that's the retina in a nutshell. Now, what are some retinal alterations? Well, when you talk about retinal degeneration, you can kind of localize it either to the inner retina, which you're usually talking about the ganglion cells and the bipolar cells, the inner aspect of ganglion cells there, the inner aspects of the retina, or the outer aspects. And mainly there you're talking about photoreceptor cells. So if we look at it, we've got some ganglion cells here. The inner nuclear layer looks pretty good. Marked thinning of the outer nuclear layer, and notice there's now some dropout of some of these nuclei down into the layer of the rods in the cones, these photoreceptors here. And this is an example of a dog with PRA, progressive retinal atrophy. And now, just to show you some of the lesions that can occur, there's loss of photoreceptor cells here and movement of these nuclei down into that area. When there's, again, if we look at the layers, ganglion cells okay, internuclear cell layer okay, we've got an outer retinal degeneration or atrophy. Here, there's only a single row of photoreceptor cell nuclei. There's marked atrophy of these photoreceptor cell interprocesses, and there's total loss of the outer segments here. And this happens to be from a sheep that had bracken fern, and it's an example of the toxicosis, the retinal toxicosis associated with that. But anyway, I only use it here to want to mention that in general, when you talk about nutrient deficiencies, toxicities, and inherited retinal conditions, it's usually the photoreceptor cells that are involved. This is an example of, this is from a calf that had a vitamin A deficiency. Actually, now we're to the point where there's complete atrophy. It's focal and complete atrophy of all layers. But in nutrient deficiencies, it's the photoreceptor cells that tend to be involved. Also, if you want to lump light in with toxic agents, this is from a rat. This is the retina from a rat. And you can see there's marked retinal degeneration present here. Now it's hard to say. It's pretty much all layers are involved. And this is a light-induced retinopathy. So be aware that light can cause retinal damage. Now, in comparison to those that I just showed you, when you get alterations that involve the inner aspect of the retina, you're probably dealing with glaucoma, or you're dealing possibly with an optic nerve lesion. In this particular case, notice we don't see any ganglion cells. Now the inner nuclear layer is shrunken down, so there's only a single cell layer present. So it's clearly the inner aspect of the retina is involved. So now we're looking at either pressure or possibly pressure from the glaucoma, or possibly optic nerve lesions resulting in death of the ganglion cells and the inner aspect of the retina. This is the retina from a calf that had an in utero infection of BVD. I use it just to show that the retinal pigment epithelial cells will migrate up into the retina. That is one thing that they'll do when there is necrosis of the retina. So this is kind of a non-specific change, but it is a change that you can see. There's marked dysplasia now. It's dysplastic. It's kind of post-necrotic dysplasia within the retina from a calf that had a BVD infection. Retinitis can be caused due to a variety of agents. In the literature recently, or in the past few years, heard about Toxocara canis larvae migrating through the retina. Probably in the Midwest, we always worry about Balis ascaris procyanus, the roundworm of the raccoon, which also has a predilection for the globe. And here we can see the larvae in the retina. Retinitis is inflammation of the retina. Here we see a retinal vessel here. There's necrosis. There's vasculitis. Also looks like there's a thrombosis here, a fibrin thrombi. This portion right here is what's left of the retina, which is very necrotic. This is all subretinal space. There's neutrophils, a lot of fibrin, serous protein present within that subretinal space there. This is Haemophilus somnus infection in cattle. Also can use the slide to point out that the vasculature, the location of vessels will vary. In general, in the larger animals, you tend to see these large vessels, especially in ruminants, out more or less on the surface of the retina instead of down within like the ganglion cell layer and the inner layers of the retina. So we can clearly recognize this is probably a ruminant retina, and the reaction is consistent with Haemophilus somnus. Again, we're dealing with a ruminant retina here, and we can see that there's also vasculitis. This time it's lymphocytic, and this is malignant catarrhal fever. Another of the lesions that you'll see with malignant catarrhal fever, ocular lesions. Moving now on to the optic nerve. Where the cells come together, they call that the optic disc or optic papilla. So if you have inflammation of the optic papilla, it's a papillitis. If you have a lesion that is adjacent to the optic papilla, you have a peripapillitis or a peripapular lesion. When there is edema of the optic disc, then you'll see it's called papilledema. And this is an example of papilledema. Probably the most common cause of this, or at least in the literature, you'll see it reported with vitamin A deficiency in calves. There's constriction of the optic nerve, and you end up with edema of the optic disc, forming this papilledema. You can have, as I mentioned before, you can have inflammation of the optic nerve, which is, an optic neuritis. This is the cross-section of optic nerve, and I do recommend that you look at both longitudinal and cross-sections of optic nerve. That this is a localized inflammation within the optic nerve, and this is due to encephalitizoan caniculi. I mention that because really the eye is an extension of the brain. So when you talk about optic nerve, really everything that you can think of dealing with the brain and alterations of the brain with the glial cells and the axons, with axonal spheroids, all of that now applies because you're really dealing with an extension of the brain here. Same is true when you talk about eyelids. Much of that's covered by skin, so dermatopathology will come in talking about lesions of the eyelid. The optic nerve has meninges. As I said before, it's an extension of the brain, so there's meninges that extend along the optic nerve. So here we have an optic meningitis. Cryptococcosis is a disease in which you frequently see an optic meningitis. This is from a cat with feline infectious peritonitis. Again, that is one where you almost expect to find a optic meningitis. The optic meninges may undergo neoplastic change. Another cause, in addition to the enlargement of a zygomatic salivary gland in the dog, is an optic meningioma. Many times these optic meningiomas contain bone and cartilage, and they just encircle the globe. The ophthalmologists always fear that they'll extend backward involve the brain. I've never seen one do that, but they clearly will totally involve the whole orbit and push the globe outward. So an optic meningioma in the dog. Moving on to some other accessory ocular structures. I mentioned this before. This is chemosis, talking about the conjunctiva. Edema of the conjunctiva is chemosis. We see a turtle. Turtles do have eyelids. These eyelids are closed, or the palpebral fissure is closed here. And underlying that is probably a lot of buildup of keratin. You get squamous metaplasia associated with vitamin A deficiency in turtles. And this is like a classic appearance of vitamin A deficiency in turtles. Snakes do not have eyelids, but they have a spectacle or a brill that covers the cornea. And when there is faulty shedding or incomplete shedding of the skin, that the spectacle may be retained. they're opaque and the snake is blind. If the snake is blind, then they may not eat, and then they'll run into problems with anorexia. But anyway, that is a problem with faulty shedding of the skin of snakes, is a retained spectacle, and that's what we see here. I tell the practitioners, don't go in there and try to peel that off. It's very dry, and you want to soak these. If you just peel that off, chances are you're going to be looking at the lens. Okay, moving on to eyelids. Probably a very common lesion of the canine eyelid is the Meibomian Adenoma. And some of these, many times they're just composed of, looks like reserve cells, and some will refer to it as an epithelioma. Very few of them actually turn out to be carcinomas, and even if they do, they rarely, if ever, metastasize. These are basically benign lesions, a common lesion in the canine eyelid. Associated with that, and here we see the eyelid that I've sectioned in that, and that Meibomian gland sits, this is a portion of it, sits right there where you change from skin to mucosa of palpebral conjunctiva. When you get inflammation or any alterations in those Meibomian glands, they're a sebaceous gland, you get a granulomatous inflammatory response to that lipid that is now extracellular. And the term for this granulomatous blepharitis basically is chalazion, and it's in the notes. Squamous cell carcinomas, we see those in cattle and we see them in horses, and they're fairly straightforward. Also, the gland of the third eyelid. You may get neoplasms of the gland of the third eyelid, and I believe in the near future there will be a report on this discussing the biological behavior of those. A particular condition that is seen in the dog, which has gone, people have termed this condition, given a lot of different names. They call it colloid granuloma, they call it nodular fasciitis, they call it nodular episcleritis, and there's many others. I think, I'll see if I can remember, I call it nodular episcleritis, but it also can occur on the third eyelid, and it may involve other sites. But I think it's called, let's see, canine nodular granulomatous Choroidal episcleritis, or something like that. There's a report in the literature, and you can get the exact term for that. But anyway, basically, this occurs in dogs, and it occurs at the limbus, or you may see it involving the third eyelid. It is composed of a mixed population of cells. There's lymphocytes, plasma cells, macrophages, fibroblasts, and it can vary. It can be mainly lymphocytic, mainly granulomatous, in which you might be thinking about a fungal infection. It can be quite variable, but it is usually a mixture of these types of cells. This is a localized inflammatory reaction that is unique to the dog. The ophthalmologists are very aware of this lesion, and so when I see it, and it's quite common. And recently, I think the current therapy is treated with cryotherapy. Now, the conjunctiva does have their lymphocytes there, and you may see, with chronic conjunctivitis, you may see little white nodules, which is just a proliferation of lymphocytes and lymphoid nodule formation. In the dog, it's pretty nonspecific. In the cat, they thought it might be due to chlamydia, and possibly in sheep. But what it indicates is just chronic conjunctivitis. This is a section from a rat. We see the retina here and the Harderian gland. Just to mention the epithelial necrosis, and then later on the squamous metaplasia of the ducts that you see with the Ciliary condition. And it's due to a coronavirus. So actually, this is my last slide, so maybe I sped up or made up for lost time. So this is a Valentine gift from one of the histotechs at Michigan State. And so if nothing else, I hope that this has been a quick overview of some of the terminology used in ocular pathology, and hope that I've kind of stimulated a love for the eye.